Dr. Papidala.
Mr. Chairperson, learned participants, good afternoon and Assalamu alaikum. My talk is on diagnostic and therapeutic dilemma of a wide complex tachycardia. This talk is in favor of Asia Pacific Heart Rhythm Society. A 70 years old man presented with decreased consciousness, dizziness, respiratory infection, low normal blood pressure, no history of myocardial infarction, heart failure. He was on amiodarone therapy. His biochemical reports were unremarkable. There was evidence of mild respiratory infection. ECG showed a wide complex tachycardia. Echo was unremarkable with normal LVEF and there was no regional wall motion abnormality. Coronary angiogram showed non-obstructive minor coronary artery disease. Surface clinical ECG showed a spontaneously induced a wide complex tachycardia, irregular, non-sustained, RBRI morphology, monomorphic, top normal QT interval, positive concordance at chest lead, and it was negative at 1 and ABL. Patient was hemodynamically almost stable. What are the possibilities of this wide complex tachycardia? First comes ventricular tachycardia group like left ventricular ischemic VT, VT arising from papillary muscle and vesicular VT from left ventricle, mitral annular VT and VT from LV outflow tract. The second possibility was SVT with aberration. Third possibility was left-sided WW accessory pathway. It may be antidromic tachycardia or other form of pre-excited tachycardia like atrial fibrillation, atrial flutter or atrial tachycardia. Atrial flutter with 1:1 conduction, pacemaker mediated tachycardia, electrolyte imbalance, especially hyperkalemia. From Brugada, Brecki and Williams algorithm for diagnosis of wide complex tachycardia, there was little point, there was few points against the BT, as there was no capture bit, evidentiation, fusion bit, and few points were in favor. It is a wide complex. In B1, it is almost monophasic, and there is rabbit ear, left rabbit ear, but in B5, B6, you see, there is no support of BT. There should be QF and RS ratio should be less than 1. So, the possibilities of BT and SBT with aberration is less. But one point is here, positive concordance at chest lead. It may also occur in left-sided, left free wall pathway, but in case of BT, the negative concordance is more reliable. From clinical history, we can identify the wide complex tachycardia. More the longer the age, more chance of VT. Symptom does not correlate with the severity of the disease. Presence of underlying disease like coronary artery disease, prior myocardial infarction and heart failure, chance of BT is more than 90%. From history, we can exclude pacemaker mediated tachycardia and electrolyte imbalance and drug associated arrhythmia. Now comes the drug. Termination of wide complex tachycardia with beta blocker, calcium channel blocker, digoxin, adenosine strongly suggest SVT. Lidocaine termination suggests ventricular tachycardia. Amiodarone or procainamide can terminate both. So we put the patient in the cath lab for differentiation and confirm the diagnosis of wide complex tachycardia. In the cath lab, after putting the catheter in the heart, patient spontaneously develop long pause. You see, there is a long pause. What do we do now? Whether pacemaker implantation or to see the end of arrhythmia. We decided to go the end of arrhythmia. At the same time, another tachycardia induced in the cath lab. It is almost same the clinical tachycardia, but it is regular. The clinical tachycardia was little bit irregular. Baseline ECG. In the cath lab, our diagnosis by various maneuver, we conclude that it is a case of left-sided, left free wall WW syndrome, possibly pre-excited atrial fibrillation. So in cath lab, we started for ablation, intercardiac mapping done. You see, this is the delta wave and this is the mapping catheter, and it is quite earlier than the delta wave. And we ablated here. You see, it's quite separation of the A and V, and VA dissociated. So the WW pathway gone. And after that, we studied and found that there was VA block. So antegrade and retrograde conduction system was gone. No, not moving. This is the transeptal puncture, and see the CS catheter, and after transeptal puncture, this is the ablation catheter. We placed it in CS 3 and 4, 2 and 4, and ablated there. Now, the clinical tachycardia is here, and post-ablation, after ablation, the QRS complex is no more wide, and it is narrow complex with sinus rhythm. But the patient, we kept the patient for a few days for observation with temporary pacemaker support for 7 to 8 days, occasional pacing beat. And before discussion, before discharge, this ECG showed, gone. Conclusion, white complex tachycardia may be sometimes diagnostic and therapeutic dilemma. Clinical arrhythmia and arrhythmia-induced in lab may not correlate. Drug may modify the or eliminate the clinical arrhythmia. It needs larger study for this conclusion. Thanks, sir.